Hi there, I'm Eve Finn, a pharmacist with Epic Pharmacy Icon Group. Today, I'll talk about planning the implementation of pharmacogenomics in Australian healthcare organisations. I have experience as part of a project group at Icon exploring the field of pharmacogenomics and planning implementation. Now, this presentation is a broad overview of planning. It's not specific to infectious diseases, but it's relevant to all practice areas. So I'll give an overview of the benefits and limitations of pharmacogenomic testing. I'll provide insight into current opportunities and barriers in this field, and an overview of the key decisions to be made when planning a pharmacogenomic program. I'll mention an oncology example where testing can potentially prevent fatal toxicity reactions. Firstly, an explanation of pharmacogenomics. It is the combination of pharmacology and genomics. It is an emerging field of precision medicine where medication is tailored to the individual based on genetics. Pharmacogenomics has application for both germline variations, an individual's inherited cells, and somatic variations, an individual's mutated or tumor cells. And this illustration is a basic representation of pharmacogenomics, where depending on a pharmacogenomic result for a drug-gene combination, a patient may require a lower or higher dose or an alternate medication. And the prevalence of these actionable results are common. In fact, a study of 5,400 Australians analysing just 4 pharmacogenomic genes showed that 96% had at least one clinically actionable variant. And this figure is in line with US data. Internationally, pharmacogenomics is becoming embedded into healthcare. The potential benefits include safer drugs first time, as a pharmacogenomic test result can potentially inform the most appropriate drug and optimal starting dose for the individual. Reduced incidence of adverse drug reactions, more accurate methods of determining dosages rather than, for example, body weight and age, and individualized dosing, whereby the dose is tailored to the person and their unique genetic profile. Potential limitations of pharmacogenomics include complexity, with many genes involved in a single drug metabolism pathway, lack of awareness amongst clinicians and health professionals, lack of national guidelines for pharmacogenomics, and international guidelines are adopted, out-of-pocket costs due to limited Medicare rebated testing in Australia. The turnaround time for testing may preclude timely initiation of therapy, and availability of testing. Tests may need to be sent interstate, and then this affects the turnaround time. In Australia, there is potential for broad application of pharmacogenomics. Currently, implementation is in its early stages. There are only 2 Medicare subsidised pharmacogenomic tests, thiopurines to prevent dose-related toxicity, including neutropenia, and abacavir to prevent the severe cutaneous adverse reaction. There are also some limited hospital-funded programs, and there are single drug gene tests as well as broad panel tests available commercially. Typically, a single gene or panel test costs between $100 and $250 and is funded by patients. Now, this graph is from the Royal College of Pathologists, Australasia, from their position statement on the utilisation of pharmacogenomics in healthcare. On the y-axis, we have the PBS-listed medication with high-level pharmacogenomic evidence for a lack of efficacy or safety, including risk of lethal reaction, which is marked with the asterisks. And then on the x-axis, we have the estimated number of patients taking the drug on the PBS. And on the graph in green, the number of patients likely to have a risk variant. Now, this is a little old as it used 2017 PBS data, but it does provide insight into the potential for broad application of pharmacogenomics in Australia. Now, I will note that the frequency of risk variance is based on CPIC biogeographic data for Western European populations. So considering the diverse heritage of the Australian population, there are limitations here. Now, as well as the potential for improved safety and efficacy for consumers of over 30 PBS medications, the clinical validity and utility for certain drug-gene pairs are strong. There are freely available, evidence-based, regularly updated resources and guidelines, such as CPIC, the Clinical Pharmacogenetics Implementation Consortium, and PharmGKB, the Pharmacogenomics Knowledge Base. And these resources provide clinical guidance for a growing number of drug-gene pairs to assist healthcare professionals with clinical decision-making. And these resources are essential for the implementation of pharmacogenomics into routine clinical practice. Now, there is evidence supporting cost effectiveness or cost saving for the healthcare system, and there are resources available to model the economic impact of pharmacogenomics. Now, there is a challenge ahead for the implementation of pharmacogenomics. The barriers include the workforce capacity and capability, and the challenge here is planning and building a skilled workforce, including upskilling our current workforce with required capabilities. Similarly, the lack of awareness amongst clinicians and health professionals. The pathology logistics, specifically turnaround time and cost, as mentioned earlier. And whilst pharmacogenomics is usually cost-effective or cost-saving, the economic benefits and cost savings may be realised downstream or elsewhere in the healthcare system, and possibly at a later stage as the tests have a lifetime relevance. So this poses a barrier for the individual or organisation incurring the upfront cost of testing. Now I'll address the key decisions when planning a pharmacogenomic program. Looking at pharmacogenomic programs overseas, there are many different types of clinics and service levels, but often programs begin with single drug gene pairs and grow from there. The cost difference is approximately twice as much for a panel, which tests many more drug gene pairs. The next consideration, when to test. So preemptive testing, such as a healthy young adult undergoing a broad panel test for future relevance, versus reactive testing. For example, a patient prescribed an antidepressant for the first time, or even a patient who has not responded to multiple antidepressants and is looking for a reason why. Then there are different service models and types of clinics, such as inpatient, outpatient, direct-to-consumer, and then the level of service and the number of consultations provided to the patient, the format and storage of the results. So think of the example of the young, healthy adult undergoing preemptive testing. How will clinicians or pharmacists be alerted to the test results 10 years down the track when a patient is prescribed a medication with an actionable result? And then cost and funding. And this, of course, will depend on the institution, the drug gene pair or panel, and government funding. Now, further key decision points. There is controversy over the evidence threshold for pharmacogenomic information as non-randomized controlled trial evidence, such as case reports, are used. Pathology service levels. The laboratory conducting the testing should be accredited to Australian standards to ensure testing quality, as well as ensuring the protection for the storage and transmission of genomic data. Ethical issues to be considered with pharmacogenomic testing include cost of testing, access to genetic information, incidental findings, and then potential implications for relatives. Now, it is important that pharmacogenomic test results are accompanied by results interpretation and clinical decision support, such as individualized prescribing recommendations. And then the alignment with organizational mission, objectives, and overarching strategy, and defining measures of success with performance indicators and clinical indicators. Now, here is an oncology example that I have experience with scoping and planning, the DPYD gene and fluoropyrimidines. So 5-FU and its prodrug capecitabine are widely used in cancer treatment for colorectal, breast, stomach, pancreatic cancers. Fluoropyrimidine toxicity can be severe and it can be fatal. Pharmacogenomic testing can avoid toxicity in some patients, and this is by testing prior to commencement of therapy. And this allows for dose adjustment, so patients to be commenced on half the usual dose with no loss of efficacy. Planning the key decisions seemed quite straightforward. This is a focused program with a single drug gene pair. It's reactive testing in a clinic setting, incorporated into the standard clinical oncology workup. The cost of the test is not covered by Medicare, so we investigated corporate billing arrangements and funding options to try to minimize the out-of-pocket costs to the patient. Now, high-level evidence is available. So here's the CPIC guideline for fluoropyrimidines and DPYD. The guidelines are detailed and comprehensive, and to assist with implementing this into standard clinical workflow, CPIC have clinical decision support notes, as well as translation tables. There is clinical relevance here and strategic alignment with providing the best care possible. The pathology logistics could be achieved and incorporated into the clinical workup. Now, the ethical issues include access to testing and inconsistent endorsements for testing, which I'll cover on the next slide. Now, planning for results and clinical decision support to be incorporated into the current clinical workflow is challenging in healthcare organisations with different EMRs and paper-based systems still in use. And lastly, defining measures of success with performance indicators, such as turnaround time for results, utilisation of tests, clinician satisfaction via the percentage of recommendations accepted, and the clinical indicators, such as the number of actionable results, so the DPYD intermediate or poor metabolizers, and the number of toxicity reactions. Now, it's not so straightforward. So a few things to note about DPYD pharmacogenomic testing. It does not explain all fluoropyrimidine-related toxicities. It can account for between 30 to 60%, depending on the reference source. So the absence of a variant does not mean the patient will not develop fluoropyrimidine-related toxicity. And then there are conflicting recommendations and endorsements by Australian and international regulatory authorities and professional committees. But currently, the FDA and TGA do not recommend routine genetic testing prior to the administration of fluoropyrimidines. So, in summary, pharmacogenomics is a complex field in its infancy in Australia. The prevalence of actionable variants among the Australian population is high. Published evidence, resources, and guidelines are becoming increasingly available to inform clinical decision-making. There is opportunity to personalise and optimise medication use, improving safety and efficacy for over 30 PBS medications. And the challenges and barriers outlined, while significant, can be overcome in focused programs. Pharmacogenomics will increasingly become embedded into our clinical workflow as we move toward precision medicine. Now, I hope this presentation will provide insight into planning implementation of pharmacogenomics. Please reach out or connect via LinkedIn if you have any questions about planning pharmacogenomic implementation in your healthcare organisation. Thank you.